amount of pressure that we need to deliver oxygenated blood to the brain. Think of it like your blood pressure, but for your brain. Okay. Normally we want it, like normal is between 60 and 70, and it is the difference between your MAP or mean arterial pressure minus your intracranial pressure. Okay. And remembering what MAP is. Okay, your normal MAP is between 80 and 90, and that's the systolic blood pressure plus 2 times your diastolic pressure, all divided by 3. Okay. When we're talking about intracranial pressure, our normal is between 10 and 15. And there is no real calculation for that. It's a direct measurement that we get from the brain with a intracranial monitor, okay, like a Bolt or a EVD, which we'll talk about. Okay, so it's a direct measurement. It's not necessarily a calculation. Okay? So in normal people, you and I, right, when either our MAP decreases or ICP increases, our CCP or our cerebral perfusion pressure decreases, okay? So, and that can cause an underperfusion of the brain. Now, when you have a brain injury, right, you have increased ICP because there's increased swelling. What we can do is either play around with the MAP, either up or down, to try to decrease that fluid or that pressure inside the head. So we can do it with this, right? So we're talking about intracranial pressure. That's the volume of intracranium, okay? Volume that's inside the head. That's the blood. That's the your CSF, your brain matter, okay? So it's the brain plus the CSF plus the blood. Okay. Can't do anything about the brain. Can't take away. Can't give more. Okay. So the brain matter, right, is something that we just can't do anything about. The CSF, though, we can put in a drain in the head and actually drain out CSF to decrease that CSF that's in there. And the blood is we can decrease the blood pressure, increase the blood pressure. Okay, so the CSF and the blood are the only two things that we can really manipulate to try to decrease the intracranial volume. The only other thing is, theoretically, like, we can do stuff to help alleviate pressure on the brain with surgery. Okay, so we can actually do what's called a craniectomy or craniotomy and actually take the skull flap off. Okay, so there's room for the brain to actually swell. We're not doing anything with the tissue, but we're just opening the space in order for it to have more room to swell. Okay, so the only other thing that we can do to kind of manipulate the brain. Okay. So when we're talking about this, right, the CCP, okay, and the MAP and how it relates to the MAP. So you have the intracranial pressure, which is that, volume that we just talked about, and then with our CCP being 60 to 70, what can we do to our MAP, or mean arterial pressure, in order to manipulate the CCP, okay? And really what we do is we manipulate the systolic blood pressure. We don't really do anything with the diastolic, it's just the systolic. Okay. So with that, if we can maintain the systolic blood pressure above 90, but below 110, okay, with all things being equal, we can get a CCP of between 60 and 70. Okay? Right? Like we talked about last week with that secondary brain, or yesterday, with the brain injury, the secondary brain injury, a single episode of hypotension can have disastrous outcomes. Okay? If we let the blood pressure get too low, that decreases our MAP, that increases decreases the CCP, and then you're going to have decreases the CCP, which means we're not getting enough blood flow to the brain, and you're going to have disastrous outcomes, a lot of brain tissue loss. Okay. If you have a palpable radial pulse, normally means you have an adequate MAP. Okay. If you don't have an actual arterial line that you can actually measure the MAP with, or a monitor that we can measure the MAP with, but if you can actually palpate that radial pulse, because if you have a radial pulse, right, what is the systolic blood pressure? At least above. talked about it in vascular. How about like 80? Okay. If you have the FEMS at 60, or 70, if you have carotid at 60, at least, very least, okay? Could be above that, but as long as you have a map, or as long as you feel your radial pulses, your blood pressure is at least 80. Most of the time, I know it's not above 90, but most of the time you have probably an adequate map, okay? Like we talked about, decrease the map can decrease the CCP. So when we're doing calculations, right, we want to know what that CCP is, and so we take our map minus our ICP, okay? So if our PP is 90 over 60, our map is 1/3 of 90 plus 120, so that's 70. So you take 70 minus whatever the ICP is, we'll say 10, so your CCP is 60. Okay, and that's adequate. Okay. Excuse me. When we're talking about TBIs, the initial management of TBI, while we are setting up for art lines and EVDs and bolts or whatever, right? So we kind of came up with that 90 over 110 because radial pulses have an adequate map, but really if you can have a SBP between 90 and 110, we know that you're most likely going to be doing okay. Okay, so 90 to 110 is really, without doing any maps, or any math, okay, that's really what we kind of use as our at least starting point, and then we can get into the more specifics once we have more things set up. Okay. All right. So how do we measure intracranial monitoring? Like measure the ICP. There's a few things that we have. Our first one is a bolt. Okay. You can kind of see it here and here. It basically screws into the skull, through the skull, and into the dura mater. Okay. It's kind of touching the brain. We have some that actually go into the brain, and then we actually have the EVD or the ventriculostomy that actually goes through the brain and into the ventricle, to actually drain off CSF from the ventricle. We can measure from all three, but if we're just measuring, if we're just monitoring like the ICP, we do the bolt. Basically, has no way of actually taking fluid off. So it's just like just the monitor. Okay, there's no therapeutic thing that we can do with it. It's just diagnostic. Okay. We can put it in a few different places, like we talked about, and then we do try to do this in all salvageable patients, right? We do want to know, like, if you have a really low GCS and you have a pretty decent TBI and or brain injury. If neurosurgery thinks that you are salvageable, we will most likely put a bolt in, or at least something in to monitor your ICPs so we can see what's happening inside the brain, so that we will know kind of like, do we need to go to surgery or not? Do we need to remove some of the skull flap or not? What is actually happening inside the brain? Okay. So this bottom sentence is, it is possible to have an increase in volume of cerebrospinal fluid, blood flow, brain mass, but you still have to have that normal, you can have all increase and still have a normal ICP, but as long as it's a decrease of any of the other components, okay? So it is kind of, the brain is weird, but as long as you have a map or a SBP of between 90 and 110, okay? Normally you have enough perfusion. We do need to know the ICP in order to really know what your CCP is, because if your ICP is 20, right, you're probably too high of a pressure inside your brain to actually get good perfusion. So we do need to know both, and there's ways that we can manipulate both. We can either increase your map with your pressors, or we can get mannitol to decrease the fluid inside the brain. So there's stuff that we can do. We'll talk about it. All right. Which of the following changes of components of the cranium best explains the pathology of intracranial pressure? What do you think?
All the above.
Okay.
Increases rate times mass, increases pressure, also increase volume, decreases pressure.
Okay. Alright. I'll give you that one.
All the above.
Technically, the answer is A. If you increase the volume within the cranium, that increases the pressure. Right? But sure. We'll move on. Alright. GCS, this is not the first time you've seen this. You will be required to know this and accurately, given a patient description, give me what a GCS is. Okay, so I would know this. Just remember that if you have somebody who's intubated, okay, there's a T at the end. So if you have somebody who's, GCS of 8, but they're intubated, it's a GCS of 8T. Just how we indicate that they're intubated. And that if you are a 3, okay, 3 is the lowest possible number. You cannot have 0. You cannot have 2. Okay, even if they're intubated, you still have to give them a 1. Okay? Now, can I potentially, have I had a patient with a verbal response of they are oriented and intubated? Yeah. Right? They're intubated, but they're not sedated enough where they can actually write. It's not a true verbal response, but they know what day it is. They can write their responses. They can ask me things on a whiteboard. They're just on a vent because their lungs can't keep up, or they're on a trach. Okay? So, have I given somebody with a GCS of 15T? Yes. It's very rare, but it can happen, especially in our, the longer we have them in the hospital and the more we can get them oxygenation and awake, then we can potentially have them be actually oriented, okay? So that is a possibility. It's not gonna be on the test, but it's a possibility that when you are rounding on these patients, if they are, following commands, right? And they can shake yes or no, like, are you in pain? Yes, are you, like, that kind of thing. They're kind of oriented, right? They may not be able to give you a vocal response, but they can at least answer your questions correctly, right? So, there is possibility for 15T, just not that common. Okay. When we're talking about disability, we talk about pupillary response, okay? You want to know if it's symmetric, right? They should be within 1 millimeter of each other. We're talking about reaction to light, okay? If you have less than 1 millimeter reaction with a bright light, you most likely have a fixed pupil. And the normal size in an adult is less than 4 millimeters. So, if you have something that's fixed and dilated, you most likely have a ipsilateral or unilateral injury to that side of the brain, right? You do have to know the difference between hyphema and subconjunctival hemorrhage. Okay, so hyphemas are blood that pools in the anterior chamber. So this is right behind the cornea. It can actually cause people to temporarily go blind per se because they're trying to see through blood. If it's full enough, I've seen it where it's actually the whole anterior chamber is full of blood. Okay, so hyphema versus subconjunctival hemorrhage is blood of the conjunctiva. Okay, that can happen with a hit to the eye, severe retching. Basically you're breaking the little blood vessels of your sclera or of your over your sclera in your conjunctival layer. Okay, so it looks very different. Okay, now could you have a hyphema plus subconjunctival hemorrhage? Sure. Okay, if you have that much damage to the eye, your anterior chamber could have blood as well as your sclera having broken blood vessels. Okay, so it is two separate things. All right. Non-trauma causes of abnormal pupils. So this is why a lot of times we ask for, have you done anything? Are you on anything? Okay, but also hypoxia can cause abnormal pupils, hypothermia, hypotension, orbital trauma, atropine of the eye, like atropine drops, right? All sorts of things. Now, they also can just be a anomaly, like I have two different sized pupils on a normal day. You wanna see it, they look different, right? So, it just depends, and if you know, so like if I ever are in a trauma, okay, I would, and hopefully they ask me, hey, are your pupils always kind of a little abnormal? Like, are they two different sizes? And I can say yes, hopefully then they don't make me go through all the different things since we're up in a different size pupil. But so there's anomalies. Like a lot of times, you also have to ask or try to ask or ascertain if this is a fake eye. Okay, we've had that before where someone comes in completely shit-faced and they have, you know, blood all over. They were in a fight, they were in something, and we then see a pupil that doesn't react to light, and it's a very good prosthetic, right? And then finally they, you know, wake up enough. They're like, yeah, no, it's a fake eye. It's a glass eye, right? Sometimes you can't tell, and you're not gonna go poke the eye to see if it's glass. So if they are, you know, if they don't wake up enough to tell you, sometimes you can be fooled. So hopefully they're awake enough to tell you that they have a, you know, a prosthetic. Okay. When we're talking about decreased LOC, what kind of labs we want to do, it's the same in every trauma lab, right? All the CNP, CBC, electrolyte panel. We'll also do the liver panel to make sure that we're not dealing with like an encephalopathy type picture, okay? Because not everybody who's found down is a trauma patient. We want to do our internal blood gas, toxicology screening. We might, if they are febrile or they have a super high white count, you know, we'll do blood cultures. We may do a lumbar puncture to do CSF, okay? And potentially doing the thyroid test and vitamin B12, right? Because someone can come in altered, they can come in at a myxedema coma, they can come in with, you know, thyroid storms, right, where they're altered, right? So there's doing that thyroid function test and the B12 and serum cortisol, if we are considering an endocrine type picture, is very important, okay? Not everybody who comes in altered is a trauma patient. And so we have to keep that in the back of our head. Okay, imaging of choice, emergency T-head without contrast. We want to do that pretty quickly because if we do have, you know, intracranial hemorrhage, we want to make sure that we diagnose that really, really quickly so that we can get neurosurgery involved versus a normal head CT, then we can work up other things. If we're thinking more of a hemorrhagic type stroke picture, we'll get that non-con head CT and then potentially go straight to a CTA of the brain and neck to see if we're dealing with a hemorrhagic or a ischemic brain injury. Okay. Anybody who is high risk for TBI, so anybody with a moderate TBI, so moderate like GCS or mild GCS with a with loss of consciousness history. Anybody who's on anticoagulation, if they're over the age of 65, they have a history of seizures or are in a seizure or fell and had a seizure and any focal deficits are going to get a head CT. Okay, you come in and you are 65 and you're on warfarin and you were just found down, you're getting a head CT. Okay, because any little bump, just a little bump of the head can cause a lot of bleeding and a lot of detriment. So we don't want to miss those. You guys talked about ischemic strokes in EM. You're good with strokes, right? So we really want to try to do it. You know, this is why we try to do the CTA of the brain, or maybe an MRI or MRA of the brain. If the CT head without contrast is normal, because ischemic strokes within the first 3 to 4 hours may actually be not visible on their initial head CT. Okay, so if they come in and they're a stroke-like picture, they were just found down, and their head CT without contrast is normal. Okay, going and then doing an MRI is super, or a CTA, whichever is on the algorithm next for strokes, right, is extremely important so that we can find that hemorrhage or that ischemic stroke. Doing the brain MRI, okay, again, diffuse axonal injury we can see severe edema on it, we can see that loss of gray-white matter attenuation. We can, if we see something on the MRI that's like a mass or something, or the tissue just doesn't look right, we'll follow up with a brain MRI to look for the characteristics of the classic type lesion. But MRI should not be relied upon for emergent diagnosis. Okay, even right now at Fancy, like they have one MRI right now. So like, if you think you need an MRI, you're probably not going to get it. Okay, so a lot of hospitals do not have emergent MRIs. And then ECGs or EEGs, so electroencephalograms. These are somebody who we want to kind of confirm global cerebral dysfunction. We need to exclude the staticus epilepticus. You know, basically it's, if they have a subclinical seizure, we need to do the EEG to kind of rule that out. Now, these are also sometimes hard to come by because neurology will push back and say, oh, they don't need one. But like you can do one for 15 minutes, you can do one for 2 hours, you can do one for a day, you can have one for multiple days. But you really have to have a tech there to do it. So if neurology is like, yeah, I don't have a tech there, it might be hard to get one. And then after we kind of rule everything out, okay, everything else out, then, you know, we really should push for an EEG so that we can kind of have that final little, like, there's nothing else going on in the brain. But in anybody who has altered LOC, and we can't find what's wrong, they should get an EEG, okay, because there's probably something else going on with that altered mental status. Alright, imaging. Going back to that CT, we're looking for symmetry, we're looking for skull fractures, mass effects, soft tissue densities, aerocyte sinuses. So this is a anagram, I think it's called, right? That a actual neurosurgeon taught me, so now I'm teaching you. Okay, so how you read a head CT and how you then consult the neurosurgery, they want this. Okay, they want so the anagram is blood can be very bad. So if you remember that, every time you're reading a head CT to get your information to tell this neurosurgeon, you won't miss anything. Okay, so blood, are there hemorrhages? Where is that hemorrhage? There might be multiple hemorrhages. Okay, we already talked about subdurals, epidurals, subarachnoids, intraparenchymal, and intraventricular. Those are the only 5. Okay, no other parts of the brain that can bleed. That's it. Nothing else in there. Okay, so blood. Is there any hemorrhage? Looking around, there are different like windows or different screens on the CT, so you just have to make sure that you're not like in the bone window, or you know, you're in the right viewing window to actually see the blood. Okay, C is cisterns. Okay, so you'll see here there's a specific slice of the CT where you see the little space between the cerebrum and the pons. Okay, you should have that black circular, half circular, or at least some area of CSF fluid that's visible, okay, around that pons. Okay, you can see it here. It's a little more closed here. But is it open or closed? And closed means it is so edematous that there's no cistern open. Like the cistern is completely swollen shut. Okay. B, the second B is brain. What is the, can you tell the difference between the gray and white matter? Is there a midline shift? Okay, we'll talk about midline shift in a minute. But you can see, like, there's differences on pretty much all of these where you can see the difference between, you don't necessarily need to know which one's which, but you can at least see that one is a darker gray than the other. Okay, that's gray and white matter. Okay, but if you have, you'll see, I think we have an image of a EAI later on where it's like you don't have any differentiation. You'll kind of see the difference, but you can see those little, you know, gray and then, you know, a little bit of a lighter gray on top. That's gray white matter. As long as you have that differentiation, then you're good. Next is the V, the ventricles. okay? These are, that's a good one. Okay, you should have two, you really only need to know about the two, okay, the two main ones, the two big ones. Okay, first and second, right? Are they open? Is one completely shut because of mass effect? Are they symmetric, right? Are both of them kind of swung over? Are they both completely shut? Like you scroll through the CT and you don't see anything? And then the last B is bone. Okay, go to the bone window and actually look for skull fractures. Okay. So this is the order in which they want, and this is, you know, a good anagram that kind of like go through and kind of keep in the back of your head, like when you're looking at CTs, that this will help you, whether it's for trauma or looking for, you know, lesions or whatever, okay? So, I would know that. Alright, so cerebral edema, right? Loss of gray-white matter. Okay, so normal, you have that distinction of gray and a little bit whiter gray, okay? But you don't see those groups in sulci. You don't see that differentiation, okay? You have that loss of gray-white matter differentiation. So that means that this is cerebral edema. Okay, the brain is swollen. All right, midline shift. You're basically looking for that box and you're kind of picking a point and saying, okay, this is the middle, right? Where the box kind of go through the two hemispheres on either side, and you're looking to see from that midpoint how far over is the middle of the ventricles. Okay, the middle of the two ventricles. Okay. So they will most likely say it on the CT, like there's a midline shift of 1.1 centimeters or 9 millimeters, whatever. Okay, the amount of midline shift is important. If it's very small, neurosurgery probably won't do much, like they won't go in and do surgery, but if it's like this, they will go in and try to evacuate that epidural. Okay. So treating the ICP, elevating the head of the bed, maintaining ventilation, okay, yes, hypercarbia can cause vasodilation or it does, and increases vasodilation, which then increases the edema, which then increases the ICP. So this is, we'll talk about the hyperventilation later, but keeping having a correct O2 and not having hypoxia or hypercapnia type event is super important because it can make your edema worse, it can make your swelling worse. All right, all the herniations that we can have, it really just depends on where it is. The two that they're all concerning, right? But the uncle and the tonsillar are the two that we really pay attention to most. Uncle is where you have the cerebellum kind of coming down over the tentorium cerebelli, okay, and then the tonsillar is where you have the cerebrum going through the foramen magnum. Okay, both of these are really, really horrible outcomes. Like if you have a tonsillar herniation, you basically have killed your midbrain and you're not gonna survive. You're basically brain dead at that point. Okay, there is no coming back from a tonsillar herniation. Okay, that is your breathing center. That is your midbrain is basically how you survive, how you are upright right now and conscious. Yes, your other brain does a lot of things, but this is like the main point. If you don't have that, you're kind of a vegetable. Okay, you don't have any of your normal reflexes to breathe, to be awake and be conscious. Okay, so tonsillar herniation is probably the worst. Okay, all right. Briefly going over our internal or intracranial hemorrhages, so you kind of remember, right? So subdural crosses those sutures. It's more of a crescent. Okay, epidural does not cross those sutures, meaning it's more of a football. Intercerebrum or interparenchymal, same thing, is actually bleeding into, like, the brain matter itself is bleeding. Okay, it's a bruise of the brain. Okay, going through the differential again for subdural versus epidural. Okay, subdural rupture of the veins more so in the elderly can occur with much less force. Can be acute on chronic and or chronic subdural. Okay, so if you look at a CT, you may have somebody who's got some old blood in a subdural hematoma from a multiple falls, multiple hitting their heads. They may have new bleeding within an old subdural. So you'll be able to tell with those Hounsfield units on whether or not it's a acute or chronic. Okay, and then epidural, you're more so looking at the middle meningeal artery. Okay, so those temple injuries. Okay, and you'll have a lucid interval. Okay, they'll get hit, they may have loss of consciousness, they'll be up, they'll be like, oh, I'm fine, I just have a headache, whatever, and then they'll be fine until they're not, and then they have enough blood accumulation in their head that they go comatose. Okay. All right, diffuse axonal injuries. These are a traumatic shearing of your axons. Okay, so this is your counter-coup injuries, twisting, rotational forces, force injuries, child abuse, like that shake a baby syndrome. Okay, your CT may appear normal. Okay, you might not have any bleeding, any midline shift, nothing. Okay, but when we do the MRI, you'll see that loss of white matter or white and gray matter pigmentation. Okay, so this is a little bit harder to see, but the history and the MRI is really what kind of helps lead us to this. Okay, once you have kind of torn those synapses and torn those neurons, you can't get them back. They're not going to grow back. Okay. All right. This is a good slide to highlight. It is a overview of basically the rest of the lecture. Okay. The rest of the lecture goes more in depth and gives more concepts, but this is a great slide that really kind of gives you the brief overview of the key pearls, right, of TBI and head injury management. Okay. So keeping your blood pressure above between 90 and 110, you can increase the head of the bed to 90, 45 to 90 degrees, 30 to 45 degrees, okay, so a little bit of head elevation, have gravity kind of help pull some fluid down. We can remove the CSF with an EVP. We don't use hyperventilation anymore. Hyperosmotic therapy, we normally use 3% over mannitol, which we'll talk about, judicious fluid, sedation. So RAS is that rapid assessment of sedation. Okay. All you guys right now are a RAS of probably -1, maybe? Yeah, maybe 0. So like I'm a 2. I'm up here, I'm alert, I'm awake, I'm talking to you, right? So a -2 is we want them sedated to the point where we, if we touch their hand, they may open their eyes, but it's very slow. It's they're sedated so that their brain can rest. This can go all the way to -5 and all the way to +5. So you have that person who's kicking, screaming, being a complete maniac. Those are probably a +5. Okay, we want those to be a negative. So negative numbers equal sedation. Positive numbers are more agitation. Okay. Fever management, so neurostorming. Okay, we don't go into neurostorming too much in here just because it is a critical care concept versus a PA thing. But we can, because of the brain and everything, it kind of short wires some circuits. And so we can have neurostorming, which causes fever for no reason. Okay, but keeping them cool is really important. Anti-epileptic therapies, they are, we can do Keppra or Dilantin. Okay, corticosteroids, really only in specific instances, we don't really do it anymore. Barbiturates, we can use IV barbiturates to really put them into a medically induced coma. Okay, we don't use it on everybody, but for someone who has a severe traumatic brain injury, we are trying to get them through it. putting them into a medically induced coma with barbiturates, puts them into the deepest coma that we can. Okay. Therapeutic hypothermia, can be protected for brain function, and then surgery really up to the neurosurgery, team to decide what they wanna do. But they do have, the two most common ones that they'll do is the decompressive craniectomy. Okay, so that is they take off the skull, they clean out what they need to, and then they put the skull back on. So they're not anticipating a lot more edema. This would be more so for like your subdurals, your epidurals, that they just are evacuating that hematoma, and then they're putting the skull cap back on at the end of the case. The craniotomies are, they take that skull off, okay, they leave enough room for that brain to swell. So these are the swelling injuries, okay? GSWs to the head, really bad head injuries that they, like intraparenchymal, interventricular, submaractive hemorrhages. We can't really get that, there is no hematoma for us to get out. So we'll actually leave the skull cap off, okay? There's a couple different things that we can do. Some will put it in, like make a little incision in like their belly, in like their sub-Q in their belly, and put the skull cap there. Excuse me. Or they'll keep it as like a surgical specimen, they'll sterilize it so that in 3 to 6 months, the patient can come back and put it back on, okay? Or they'll just get rid of it and they'll get a titanium one or a plastic one, a surgical one later, okay? But so, craniectomy, they put the skull back on at the end of the case. Craniotomy is they leave it open, okay? So E, end of case, O, they leave it open. That's how I remember. But you'll know, like with craniotomies, like they'll actually have like once that swelling is down, you'll actually see the brain. I mean, you'll have your skin over it, but you can actually then like see, like, it's cool. They will have to wear a helmet when they leave, okay, so that they don't have any, because there's nothing to protect the brain when they leave, okay? So after a certain point, we'll put them in a helmet, until they can get the brain, skull back on. Okay. We have 68-year-old male, hit on the head, GCS is 12, pupils are equal-reactive, hemodynamics are stable. 1 hour later, the blood pressure is 190/100, right pupils larger than his left, GCS is 8. Which of the following is the next intervention needed in this patient?
GCC.
What do you want to do? What's the first thing you want to do?
Innovate. ABCs.
So go through your ABCDE.
Airway.
Airway comes first, always. Okay, so we're gonna innovate. Just decreasing their blood pressure, maybe we decrease their, maybe we give them mannitol, but that's normally not our first line. Okay, and we'll talk about it. But normally we want to innovate, we want to secure that airway, so that we can move on to the next. Okay. Alright, so blood pressure control. Like we said, we want that SPP to be between 90 and 100. We want to keep that MAP around above 70. To try to, that's assuming that the ICP is less than 20. We want to aggressively treat shock, so there's multiple times in which, these people will need 4 pressors to keep their blood pressure and their MAPs above even 55. Okay? And so there's phenylephrine, epinephrine, norepinephrine, and then there's but treating that shock aggressively with pressors to try to keep their blood pressure up. And really at that point, we're not even really caring about their SPP so much. We're trying to get their MAP above 55. Okay, 65 is really better. The neurosurgeon will specifically say, how far they want their MAP up. But at that point, we're most likely having an EVD in their head so that we can also map the ICP. Okay. Sometimes the neurosurgeon will want us to keep them hypernatremic, so 145 to 155. Okay. So that's why we resuscitate with normal saline. normal for sodium. Occasionally they'll say, no, we don't need it, we just, keep the normal, normal intensive, or, normal, nutremic. But occasionally they're so bad that we do need to increase their salt a little bit so that we can decrease their, cerebral edema. Okay. And then positioning that head above 30 degrees, or 230 degrees above the heart, okay, will help, again, gravity trying to pull that fluid away from the head. Okay, hyperosmotic therapy. Hypertonic saline, we always use first. So these are not as a maintenance fluid. These are in acute adjustments, like they are having an acute spike in their ICP, acute change in their mental status, and we need to do something very, very quickly in order to try to decrease their cerebral perfusion, or decrease their ICP very, very rapidly. So the first thing we do is hypertonic. The most common one is a 3% hypertonic saline, which is just 3% sodium chloride. Okay, so normal sodium chloride is 0.9. Now we're going to 3%. Okay. So that is normally we'll do like a 250 bolus, 250 milliliter bolus of 3% over 10 minutes to try to decrease that ICP. We try not to administer it through a peripheral catheter, a peripheral IV, because it is very caustic to our veins, so we try to have it through a central line if we can. If we don't have a central line, we'll at least start through peripheral until we get that central line placed, and then we'll move it to a central line. Okay? Try to save our mannitol for last resort, okay? Because if you give mannitol, then 3% isn't going to do shit. Okay? So mannitol is, we give pretty much like 0.5 per kg over 10 to 15 minutes. Really, really quick action within minutes, okay? And it lasts between 4 and 24 hours. So if you have somebody who you've given mannitol to, this is why we can't give it 3% afterwards, right? Because it can take 24 hours for that mannitol to work. So we could actually then cause a severe hypernatremia on accident. Okay? So we don't want to do that. So if like you try the 3% first, we'll maybe try a couple boluses of 3%, and if really we cannot get their ICP down, then we can do mannitol as a last resort. Okay? We try to avoid these in hypotensive patients. Okay? Yeah, just because they can decrease their blood pressure and then kind of negate what we're trying to do. Okay? So we use hypertonic saline for the most part. Okay. All right. What other things can we do? So in reducing that cerebral metabolic demand, okay, getting their brain to rest. Obviously, we want to do that rapid sequence intubation. Now, say somebody's got a GCS of like 3, right? Do you think you're going to RSI them? Okay. Just because they're GCS 3 or GCS less than 8, okay, you still want to RSI them because they could still have a gag reflex. Okay, that's a basic brain function. So you want to paralyze them, take over their breathing, and then they can come out of it. So you are basically RSIing everybody. Okay, it doesn't make a lot of sense. This is what an ED doc told me, because I kind of had that same thought of like, well, they're unconscious. Like I don't need to knock them down; they're already down. But just that enough stimuli in the back of their throat could cause them to vomit, and so we want them to be RSI'd so that we kind of decrease their gag reflex. We take away their gag reflex completely, so that they don't aspirate. Okay. So we RSI everybody. Okay, and then the most common use, or the most common combination that we use is propofol and fentanyl. In kind of low doses, we titrate it to a point of a RAS of -2. Okay, we want them sedated. But if they're already hypotensive, we can't use propofol. Okay, propofol will decrease their blood pressure. Okay, so in that case, we may use ketamine and fent, or if they can't, if both of them, they still are decreasing their blood pressure because fentanyl will decrease their blood pressure sometimes, it decreases their respiration drive, whatever. Yes, we can take over all of that, but sometimes we'll just use, ketamine and midazolam, or there's a lovely drug called Precedex. Okay, Precedex is great. It doesn't affect the blood pressure. Okay, so there's a lot of different things that we can use depending on how the body's going to respond to these sedation meds. But we have to get their agitation down. We want to aggressively treat their fever, and then we will do seizure prophylaxis. So any blood on the brain can have it lowers the threshold for seizures. So anybody who's already predisposed to seizures, it'll potentially make them have their seizures again, even if they're on medication. So especially for subarachnoids, we will, even if they don't have a seizure history, we're going to do a seizure prophylaxis. Okay, they're going to be on at least ketamine for 7 days to prevent seizures. Okay, so people who have blood on the brain are most commonly will have a seizure in the first 7 days of their brain injury. Okay, so that's why we treat for 7. There's been a huge study, I don't remember the study name, but there was a study that says 7 is a day. Okay, so we treat for prophylactically for 7 days and then we can stop. Now, some neurosurgeons will say, this was a bad enough brain injury, we're gonna do it for 14. It's up to them. They're the brain people. Okay, but for the most part, we'll do at least Keppra for 7 days. And if it's severe, we'll do it IV, right? If they can't swallow anything because they're intubated or they're so altered that they can't follow commands, we'll do either IV ketamine or IV phosphatidyl. Okay. We talked about, we didn't really talk about glucocorticoids, so the history of that was with severe spinal cord injuries. It'll kind of help decrease the edema of it. It's been proven that it doesn't work. It can actually make things worse, so we do not use steroids in head injuries or spinal cord injuries anymore. Barbiturates, again, those are for refractory elevated ICP, so you have a severe brain injury, and we need to really get them into a medically induced coma. This is a RAS of -5. We want them to we're screaming at them, causing bruises, from trying to wake them up with, the pain stimuli. They are not moving. Okay, they are completely down. Almost to the point of paralyzed, but it's not a paralytic. It's just to really decrease that brain activity, so it rests. And I've seen it used before. It is a rare thing, but I have one guy who got his head crushed between 2 things and had massive fractures. And so we put him into a barbiturate coma. We had one guy who had a transcranial gunshot wound. So massive amounts of bilateral, I think we both basically took off both sides of his skull. Again, we put him into a barbiturate coma because we want that brain to rest. We want them completely out and down as much as possible so that brain can heal. So it's the very devastating ones that could potentially be survivable to some degree. Well, barbiturates is what we can use to really try to decrease that ICP. And then decompressive craniectomy, craniotomy as the last resort. All right, you have a 65-year-old male with a history of depression and schizophrenia being admitted after craniotomy due to firearm injury to the head. Physical exam, heart rate 98, blood pressure is 128/84, no signs of raised intracranial pressure on fundoscopy. And then what is the most common complication for this patient following the traumatic brain injury? Anybody disagree with seizure? Let's take a 10-minute break.
So now Lateral malleolus. That's what you should keep. Yeah. It's because I'm fucking, you know, they have that rocker on. So, they better for straight line running. Alright. When that bitch got in, buckle.
I'm not even gonna lie, that meal looks fantastic. Two straws and you can't even put another drink.
That is so strange. Wow. Literally Bosch. And then the crazy part is that it's a hidden.
New Jersey. But that's not part of the So, I accidentally emailed the XF from her computer and had to go through that.
We're running share.
And more less, first UI should be
It's a freebie. Everyone gets one.
honestly, like you should probably track this down.
Trying to get legal, sir.
That's what you said. And then we're gonna have a little, it's a kitchen backpack, so it has plates, cups, forks, and all that. So it's.
Why did I know immediately when you said you were supposed to eat as I was like eating brunch? Mine has a little seat over there. There's an electric. Long seat. That would be hilarious. That's like the PSI 100 to that.
But I'm gonna cut his hair and stuff, make sure he's all groomed, good to go. Yeah, yeah. It's hot, and she has a pool, he can swim.
If he went around and really
She was really after her, it's not gonna work out, so at least they taught us how to pay for extra month of storage of their stuff, and make stuff happen. Like, I think shooting's $28. They only have a server for like 3 months, so they have to like give you have delivery space next day, like, you know, get you get started on it. So they could get some stuff.
I don't know, you need help?
Yeah,
not blind, but usually impaired. A little carpool every morning?
You gotta be comfy. Just don't fall asleep.
Yeah, because.
Although you're right there, I just don't go. It's harder for me when like they're all the way next to the wall. Alright, you guys ready?
Ready.
Alright, so elevated ICP, right? injury, okay, which is why we don't like hypo things in with brain injury. So hyponatremia can increase the cerebral edema, lowers the seizure threshold. Okay, remember for hyponatremia, seizure is a component of that, right? You can have seizures with just low sodium. If you're already at a lower threshold for seizures because of your brain injury, decreasing your sodium as well can make that even, worse. Okay, so we want to keep that up high. But what are the two things that following TBIs, so cerebral salt wasting and an ADH release consistent with SIADH can be seen? Okay, basically it is, because of the release of the BNP, it actually causes a vasodilation, which then causes that increase in edema. Okay. Basically, we just want the sodium to be normal or elevated. But one of the things when we have TBIs is they'll be normal, and then all of a sudden their first symptom is they will start putting out liters of urine over a couple hours. Okay, they will have massive increase in their urine output. That's one of our first signs of there's something going on with the sodium. Okay, so cerebral salt wasting, SIADH, and it can actually sometimes mimic you can actually have like a DI that mimics salt wasting that may require the BDAVP to treat it. Okay, knowing what the urine specific gravity is super important. Okay, so getting that UA, sending that urine off. There's very specific criteria, and the last time I had somebody who had a DI-like picture, the neurosurgeon was like, well, we have to wait for that specific gravity to get below, I think it was like 0.12 or 0. It was very low specific gravity. And so at that point, then we could give BDAVP, but they're like, well, if it's not that low, then BDAVP is indicated. So it's like very, very specific lab measurements in which then we can give it. But yeah, so we want to keep an eye out for like the urine osmolality, specific gravity, and then potentially giving that bolus of normalcy or hypertonics if we need it. Okay, this is a good chart of what we kind of see in terms of cerebral salt wasting, SIADH versus DI. Okay, so you have a serum ADH increase, whether it's appropriate or inappropriate. Okay, a decrease in your sodium serum or serum sodium. Okay, but with DI you actually have an increase. So that's why it mimics cerebral salt wasting, but it's not actually cerebral salt wasting, and that's why BDAVP may be needed if we have an increase in that sodium. Okay, so this is just a more critical care, okay, but know that you can have a massive amount of, if you have an increase in your urine output, you have to start thinking about the sodium and doing urine lights and urine osmolality and, looking at the specific gravity to see kind of what is happening, and then trying to match up, okay, what is actually happening? What can we do to treat it? Okay. When we're talking about removal of the CSF, so now we're talking about intracranial pressure due to, we've already done everything else. We've already given the hypertonic saline, sodium is up already, and the last thing we can do is decrease that CSF volume to try to bring down the intracranial pressure. So we have the tracheostomy. Okay, it's the only real one that we have that is actually a drain. Okay, and we do call it an EVD, an endotracheostomy drain. Okay, and so we drill holes through the skull, put this drain through the parenchyma and into the ventricle to try to, we can measure it and it can be therapeutic in drawing off CSF if we need to. The bolt and the tissue probe, not therapeutic, is just diagnostic. Okay, can't draw draw anything off of a bolt or the tissue probe. It basically are just monitors. Okay. And then, like we talked about, that perpetuate metabolic coma, putting them on that drug to really decrease this is sometimes the only thing we can do. And again, we want that ICP less than 20. Okay. So, if in the brainstem herniation presentation, we have the Cushing's triad. Okay, you're gonna have elevated blood pressure, or at least a widened pulse pressure, bradycardia, and an irregular respiratory pattern. Okay. If you have late signs of increased ICP, most likely the herniation is already occurred. Okay. And we've already kind of talked about the uncal herniation versus the tonsillar. Okay, so brainstem herniation through the tentorium cerebelli, which is the compression of the CN3. So impending is you have contralateral hemiparesis, decreased consciousness, ipsilateral palsies. Okay, impending, so that if you start having those types of things, like you know you need to give something to try to decrease that edema, and if it's already dilated and unresponsive, so fixed and dilated, especially with a lateral gaze, that means that cranial nerve 3 has already been compressed to the point of it's a herniation and there's no real bringing it back. Okay, we can't fix herniated. And then with tonsillar herniation, because of where it is going to have that respiratory depression and that. Okay, both are pretty catastrophic if we see them, and so we do everything that we can in order to, prevent it. One thing that you guys are learning in the ultrasound is doing the intracranial pressure with the optic nerve, right? This is super important. If you don't have a EVD capabilities or volt capability, like you can do that ultrasound and look at that optic nerve and look for that papilledema, that can be your first sign of impending herniation. Okay, that is a increased ICP, and so having that papilledema, that's why we teach you that, because it is a super important skill if you have it, so you can try to catch it early. Okay, but altered mental status, headaches, vomiting are all symptoms of ICP, increased ICP. Okay. All right, you have a 6-year-old woman who's brought to the emergency department after being an unrestrained driver in an NBC. GCS at scene was 4, intubated for airway protection, which the following physical exam findings is most concerning for severe increased intracranial pressure. Anybody disagree with bradycardia? Can you see hypotension? So not in acute, or not in like the initial impending, right? You'll have hypertension, but if you have hypotension, that means it's a late finding, and it means it's already probably herniated. Okay, that's why one of the things like putting somebody on pressors to keep their maps up is so difficult sometimes, trying to keep them from being hypotensive, because it's a late finding of herniation. Okay. Yeah, so the answer is bradycardia, but if you see hypotension, it's a late sign and something's probably already happened. All right, so last resort treatment. You can increase the head of the bed. If the BP can tolerate it, we do that secure airway. Okay, definitive airways, so, really preferred. We don't, if you can only get a supraglottic airway, then sure, but we really want that, in between the vocal cords with endotracheal intubation. And then we want to ensure that adequate ventilation. Now, I say last resort because we're going to talk about hyperventilation. This is really only taught because it is an old school method, and we're military members, and we're going to be in areas in which we have people that we don't have the ability to do, intracranial monitoring. We don't have, neurosurgery, downrange. So what can we do potentially in a last-ditch effort? We've already given them mannitol. We've already done everything we can, so what can we do in the, as we're getting the OR ready, or as we get the helicopter ready to take them to, launch school or whatever, to get them to a neurosurgeon? We can potentially hyperventilate, okay? But really, it's a last ditch effort and it can't be for long. This is not hours, this is like minutes. Okay? This is the shortest time frame that you can think of in order to get like the surgery available to try to fix a catastrophic injury. And it's for acute therapies only, acute treatment only, okay? So this is one of the things why I still mention it, because it is still in our guidelines, but it is a last ditch effort to try to get them to a surgeon who can actually do something about it. In those people who have the suspected herniations. So these are not for people who have already herniated. There's nothing we can do for them. Okay, so this is impending herniation. We can hyperventilate them, but we have to remember that because we can actually, inducing that vasoconstriction can lead to decreased CCP to the point of ischemia, right? So we can't do it for very long, okay? But we can at least try to do it to decrease. That's one other thing that we can do to decrease the CCP in order to decrease the edema in the brain. But this is not going to be an answer on the test. Okay, NCCPA, PANCE is not going to ask you this. This is really for military medicine, for last ditch effort on what we can do to try to decrease the ICP in order for them to reach a neurosurgeon. Okay. When we do it, we use capnography. We do not use colorimetric. Okay. We have to have specific in-range end tidal CO2. Okay. It has to be monitored very, very closely. So, normal, with normal respiration, right, we want 35 to 45 of end tidal CO2. We're aiming for between 25 and 35 for hyperventilation. Okay. And again, for the very shortest amount of time possible, because eventually you will actually, actually decrease the CCP and actually cause further brain injury in that case, okay? So, only a temporary measure, just to off-gas the CO2 in order to cause a vasoconstriction and decrease the ICP for a very, very short amount of time. But it's not a like every day in a level 1 trauma center, we're not gonna do hyperventilation, okay? So, it's just military medicine, just so that you know it exists. Initially, we can use the colorimetric. Remember, yellow color is the exhaling CO2, purple is we want the inhaling O2, okay? So, color change. We have these light, nice little EMMAs, which we'll actually have when we have the GOAT lab, okay? You guys will be able to play with those if you want. We have those for the ACM lab. And you can really see then, it'll, do heart rate and your end tidal CO2. You can actually see how it changes with how severe and how badly we treat the goats. Badly, and not in terms of like PETA bad, it's when we get to the point where they're not going to survive, okay? But yeah, so it's use hyperventilation only for a temporary measure, but in the long run, it will actually cause brain death and like ischemia of the brain, so you don't want to do it for very long. Alright, following a MVC, 35-year-old male is agitated, multiple cerebral contusion, MCT, heart rate is 85, the MAP is 84, intracranial pressure is 28. What's the most appropriate management regimen over the next few days? What do you guys think? Who thinks A? Who thinks B? B? C? D? E? Okay, let's talk about it. You want the patient awake with a rest 0. Okay? You don't want that. Trendelenburg, is that feet upberg or feet downberg?
That's feet up.
That's feet upberg, right? So that's opposite of what we want. Okay, we want the head up versus head down. Okay, do we want hyperventilation over a few days? No, we just talked about that, right? And then we need to increase the MAP with a heart rate of 85 and a MAP of 84. Right, that's already above normal. So putting them, we already kind of know that their blood pressure is probably already high enough to give us that. So administering that mannitol is correct. Okay, if you don't have mannitol, using hypertonic saline. Does everybody understand that? All right, so just a new overview. Remember your primary survey, manage your airways, prevent hypoxia, aggressive BP control, manage with normal saline preferred. Do not give these guys lactated ringers. Okay, these are like your one population that you absolutely want to use normal saline as your first line therapy. Okay, we want that sodium. We can add hypertonic saline for volume expansion if we need to. Hyperventilate only for temporary measures, avoid hypoglycemia, keeping that ICP less than 20. Okay, patient has blunt head trauma, GCS is 13. Even in everything stable, people are equal, reactive 2 hours later is left, people is larger, blood pressure is 180 over 105, tachypneic with an SpO2 89 on 100% oxygen, which is probably the most appropriate next step in managing this patient. Who wants A? B? C? D? Or E? You want him to die in the MRI? No. Okay, so we don't want him to die in the MRI. We don't necessarily want to lower his blood pressure, right? Because that gives us a good map. A routine neurosurgery consult, probably not. We want an emergent one. Okay? Urgent CT scanner, do you think he's going to die in the CT scanner? Don't put an unstable patient in the donut of truth. Okay? Don't do that. Don't do that to yourself. So yes, innovate and start managing. Okay, airway, decreasing the ICP. If the answer has airway in it and there's no airway that has been definitive, like probably choose airway. Okay. All right. Any questions about brain injuries? No, let's finish up with burn. Does anybody need a minute to download it, or has everybody got it downloaded? Everybody good? Yep. Alright, so burns. Love burns. Burns, if I could do burns, I probably would. Those are our objectives. We're going to talk about identification, different severities, initial management, and complications. Alright, so when we're talking about burns, the majority of this lecture is for thermal burns. Okay, we do talk a little bit about like electrical and chemical, but thermal, scalding, and so like some sort of a heat injury, okay, is the majority of this talk. So we need to know the layers of the skin in order to identify how deep this burn goes, so that we can identify like how, like the actual degree of burn and then what the treatment should be. Okay, so all you guys remember the epidermis and dermis, two most common or first two layers of the skin. Okay, integrated with the basement membrane. Epidermis is the outer layer. We get repair through regeneration of epidermal cells. Now, is this just a purely epidermal injury? Okay, any just abrasion or first degree burn, the epidermis really regenerates, right? So there is no scarring as long as it doesn't go into the dermis. Once we start talking about dermis, that's when we start talking about scars. Okay, dermis is the complex inner layer. This is where we have hair follicles, sweat glands, sebaceous cysts, nerve endings. Okay, so once we start talking about actual dermis injury, that's when we start talking about, how, if it's going to be painful or not. Okay. So BMZ, the basement membrane zone, right, in between the dermis and epidermis. This is where we have the dermal pathway, so this is where our fingertips, or fingerprints come from, okay, the ridges. And does play a significant role in burn healing. Basically, because of where the blistering would be, okay? So you gotta just know the layers. All this is review, right? So, I won't necessarily ask you specific things about like the pathophys. There's way other questions I can ask you. But if you have the BMZ that's actually intact, it'll kind of help prevent the shearing, which means it'll help prevent the blistering. Okay, so thermal burns. There are 3 zones of tissue injury. Okay. There's the zone of coagulation, the zone of stasis, and the zone of hyperemia. So ABC, you have ABC, okay? So they're all labeled so you know exactly which one's which. The most central area is the most damaged area, okay? It's the zone of coagulation. This is the area that all the blood vessels have basically been burned off. It's gonna be white, it's not gonna blanch, okay? It's gonna be the area of most severe damage, the thickest part of that damage, okay? Zone of stasis is around that, it's gonna be more pink. You're gonna have vasoconstriction and ischemia. It could theoretically turn into a zone A, or zone of coagulation, depending if it continues to what we call cook. Right, if we don't get that area to, well, it can blossom into a zone of coagulation because that area is, if we don't try to increase that vasculature to the area, that ischemia will, like, and everything else, kill that tissue, okay? Is still initially viable, but it can turn into a zone of coagulation. Zone of hyperemia is the most outermost layer, or zone, okay? This typically remains viable throughout the injury pattern. It's gonna be the most red, it's gonna be the most painful, it's going to blanch. Basically you have a lot of vasodilation, which is why it's red, the increase in white cells there, okay? So knowing the zones is really important, because if you have A, and it's truly like deep, okay? That'll be the worst part, and where we're probably gonna have to do something about, versus if it's just hyperemic throughout, we'll just watch it really closely. Okay. So, depth of injury really affects the subsequent healing of the wound. The deeper and the wider it goes, the more devastating the injury is going to be. And then assessing that burn depth really is the determination for the need of surgery. Okay, how deep it actually goes, how bad it is, will really determine if we need to take them to the OR or not. Like I said, though, like, these can get worse and it can blossom over time. So just a snapshot of like the initial injury, you're going to want to follow these because they can actually get worse before they get better. Okay. Classifications. Old school, first, second, third, fourth degree. We don't use those terms anymore, but just because everybody kind of remembers those as the main component, we have them here so you can kind of remember the relationship. Okay, so superficial is our first degree burn. It is the epidermis only. Okay, only occurs in the epidermis. It's just gonna have red skin, no blistering. You're not gonna have any separation between the epidermis and dermis. Okay. When you have superficial and deep partial, it extends into the dermis. When you have a deeper wound, which we'll talk about when we go into these a little more in depth, when we go deeper and it's when it becomes a little more hypouremic, like hypo-red, like it's, sorry, not hypo-red. basically the deeper it goes will be the worse the blister potentially, or the closer it is to full thickness, okay? And then full thickness goes all the way through into the dermis, all the way through the dermis, okay? So superficial and deep partials are our most painful, okay? We have basically our nerve endings, our blood flow, our nerve endings are exposed at this point. Okay, it's our most painful. Okay, once we get into full thickness and it goes all the way through the dermis, we no longer have nerve ending, we no longer have blood vessels, everything has been burned. Everything has been destroyed. Okay, and when we talk about deep full thickness, that's like our fourth degree, that's destruction of muscle, destruction of bone, destruction of tissue. It's all the way down. Okay, so knowing these thicknesses will be really important. All right. Before we get into a little bit more specifics of that, we have to know how to calculate our total body surface area, okay, TBSA percentage. Because the percentage of the amount of body that we have that has been burned will dictate how we treat. Okay, so knowing how to calculate this is extremely important. First degree burns are not included in this calculation. Okay, this is only second degree, or like superficial, partial, deep partial, full thickness. Okay, we do not include our superficial burns. Okay, we have three main things: rule of nines, our Palmer calculations, which is using the palm of the patient's hand, which is approximately 1%, and then we have the Lund-Browder chart. When we initially do burns, we normally do the 9% rule, or rule of nines. When we're actually in a burn unit, we will use the Lund-Browder chart. It is way more in-depth. We actually will color the chart, and it'll stay outside of the room, and we will update it every day to see if any of their burns have blossomed into worse. Okay, but for the most part, in the, like especially in the ER trauma bays, we'll use the rule of nines to get at least an estimated amount of TBSA. Okay, so I would know this, and I would know how to calculate this, right? The biggest thing, is remembering that, each leg is 18%, but you have the front and the back being 9, okay? Our chest and back are 18, but you have like the upper and lower, and then upper back, lower back, okay? So rule of nines. Each arm is 9%. There is no, it's half of the leg, right? So 9%. And then the front and back of our head. So our head is basically 9%, but you have 4.5 and then 4.5. Okay. The kiddos are a little bit different in terms of their head is 18% because their heads are enormous to their body surface area. Okay. So it is a little bit different in kiddos, but I will not be mean and I won't make you do rule of nines for kiddos because this is not the pizza class. So being able to approximately say how much TBSA percentage is burned is something that is full game for our test. Okay? Does anybody have any questions on the rule of nines? For the palmer, are you going to use your palm or the patient's palm? Because my 1% to my body surface area is going to be very different for other people out there, right? So I'm not going to use my 1% on someone who is twice as tall as me. Yes.
When you talk about for the torso, so say they have a burn injury extended to T4, you would count that as 5%?
So if it's just the anterior upper chest, yeah, 9%. Yep. Yep. So it'll be very specific as how far down. If I say anterior thorax, anterior thorax and belly, right? Upper back versus entire back. Okay. So yeah, it'll be specific. Okay. All right. Going into sunburns, okay? Without blistering. That is the key thing. Once you have blistering, now you're into superficial deep, or superficial partial, okay? So this is just an epidermis, just a sunburn, okay? There's not much treatment we do other than aloe lotions without alcohol in it. Normally heals within 3 to 4 days, okay? It can still, if it peels, it probably was a superficial, because you have that shearing of that, between the dermis and the epidermis, okay? But sunburn, don't be this guy. Don't be that guy, right? So hydrating lotions, bandaging your pain with, ibuprofen, NSAIDs, that kind of thing, okay? So superficial and partial, this is kind of the hardest because it is 2 thicknesses in 1 degree, okay? So you have, through the epidermis and into the papillary dermis, so blistering is their hallmark. So once you have blistering, now you know you're at least in a superficial and or deep partial, okay? When it's superficial though, it is pink, moist, very painful, okay? You'll have the blistering, but it'll be more pink. You won't have any white in it at all, okay? It'll blanch, it'll be probably the most painful out of all of these, okay? Deep partial, so this actually extends into the dermis, so it's gonna be mottled pink and white, okay? It will still blanch because you still have some of those capillaries still intact, but it'll be more dry versus wet, and it'll be potentially painful. Depending on how far deep into the dermis it goes, how many of those nerve endings have been destroyed, variably painful. Okay, so one area might be more painful than the other, it really just depends. But it is sometimes very difficult actually to distinguish between deep and full thickness, right? With superficial, it normally heals within 2 to 3 weeks, normally doesn't have any scarring or any functional impairment. When you get into deep, as long as they don't become infected, normally heals within 3 to 8 weeks. You will have severe scarring, okay? You will have contraction, you will have loss of function. So this is like the difference, kind of more blistering, more pink and wet versus a little bit drier and mottled pink and white. Okay. If we have any superficial or deep that has not healed by 3 weeks, more likely it's not going to heal and it needs to have excision and grafting. Okay, we'll kind of excision that dead skin off and then skin graft over top of it. Okay. Alright, so PCM goals for superficial deep. What is, you guys are gonna have these people show up to your clinic, what are you gonna do? Clean the wound, okay? If the blister is intact, meaning the blister root, the skin is still intact, okay, you leave it alone. Do not top these. That is a natural band-aid, okay? The skin is intact. Leave it intact and have close follow-up with them, because if it does rupture, which most of them do, but if it does rupture, then you can loosely debride that tissue, okay, to where, so you're not having, flaps of just dead skin, okay, because all of those little flaps are potentially ignitis where bacteria can be under and cause infection, okay, so if there's any little loose pieces of skin, we want to get those removed, okay. We're going to cover with Selvazyme, which we'll talk about. It's an antibiotic cream. We're wanting to apply a dressing, okay, normally a dry dressing. We want to ensure the tetanus is up to date, patient education. So basically the biggest thing with this patient education is sun and or trauma. So you don't want these to reburn, okay, while they're healing. That can make it worse. So having, while the skin is open, you're not going to use sunscreen, okay? But being inside out of the sun and trying to prevent any worse of these burns. Daily dressing changes, this can be very, very, very painful, okay? So sometimes either having them come in to do the dressing changes or sending them to a burn center if we need to. Over time, it'll become less and less painful as the skin heals. but initially it's gonna be very, very painful, okay? For both, superficial and deep, if it's large TBSAs, okay, if it's over joints, hands, feet, or groin, you're sending to a burn center. Do not try to treat these and just kind of follow them in your clinic. They have to be seen in a burn center, a burn surgeon has to see them, okay? Especially over joints, hands, feet, and groin, right? Those are our functioning things. If these contract because they weren't followed correctly with a burn surgeon, that's a big liability, okay? So we want them to be followed by a burn surgeon. Alright, full thickness burns, so all the way through the dermis, and into the subcutaneous tissue, so this is full thickness tissue loss, okay? It's going to be either white or black, okay? It's going to be very dry, and it's not gonna hurt. These are not painful, okay? Why do you think that is? Yeah, the nerves are completely burned. They're completely destroyed. You're all the way down now into the subcu layer. Now, the subcu layer may not necessarily be showing, but that thermal burn has gone all the way through the layers of the tissue, and now the epidermis and dermis are both damaged to the point of death. I guess necrotic tissue, and the subcu layer is the first healthy tissue-ish. Okay, so it'll actually look like white. Okay, it'll be non-blanching because the capillaries are all dead. Okay, so these do not blanch. They can appear red, but they, like I said, they do not blanch. So if you put pressure on it, it's not gonna blanch. It's not gonna turn white and then come back red. Okay. These really only heal by contraction or mitigation or migration of the keratinocytes from the periphery of the wound. So because there's just subcu layer as healthy tissue, right, it's not going to heal from the bottom up like most injuries. It's going to actually heal from the outer edges in. So that's where we see the contraction or contractures happen, because you're healing from the outside of the wound in versus from the bottom up. Okay. These have to be treated with incision and grafting. Okay, we'll talk about that. That's basically, we're gonna cut off all of this dead skin. Okay, all of that white non-blanching skin, we have to cut it down to healthy subcu and or as low as into the dermis as we can to get healthy bleeding. Burn surgeries are extremely bloody because we want to get down to healthy skin or a healthy layer. So we want bleeding. If we don't get bleeding, we haven't removed enough. Okay? And then we'll there's a bunch of different things in which we can do, depending on if they have any tissue that we can graft from, being our donor site. We can take that donor site and then graft it onto wherever that burn is. If they don't have any donor skin because they're 90 plus, percent burned, there's other things in which we can do to try to hopefully heal some of our lesser burns to the point where we have epidermis, so then we can take from that area and put it on our more severe areas, but sometimes that's not possible. If they have an eschar, okay, eschar meaning, remember what an eschar is? It doesn't burn, it doesn't have to be burned skin, it's just dead skin, it's necrotic tissue. Okay, eschar is necrotic tissue. It'll look black, okay? So we have eschars with chronic wounds, we have it with burns, okay? But it's just necrotic tissue. We have to remove that necrotic tissue. Bacteria can live underneath that, we become infected. So we wanna make sure that we remove as much of that necrotic tissue as possible. Okay, treatment. So if they show up to your clinic, right? The initial treatment is the same as a partial burn. You're going to clean it as best you can. You're going to, dress, elevate it, and then send to a burn center. Okay. It needs to be seen by a burn surgeon. Now, I have had some where it's like, well, it's only 0.25%, like a little, not quarter, but like literally the size of a quarter, and it's like a third degree or a full thickness burn, and I'll call the burn center and I'll be like, hey, I got this guy. He doesn't need to be seen urgently, but can I get him on into the burn clinic to be followed? And they'll say yes. right? So there's the difference between at least getting them to a burn center emergently versus for clinic. So you can call the burn center, they're very apt to answer questions over the phone, because they know that they're the burn center for whatever area you're in. You'll have a designated burn center. And so, they'll be able to answer questions. You can send them, a lot of times you can send them pictures, so that they can really identify, like, okay, does this person need to be sent today? Like, do I need to send them straight from clinic to the burn center? Or can they set up a follow-up appointment in the next couple of days? Especially, like when I was in Jacksonville, I had a bunch of these where it was like, you know, the burn center was in Wilmington or in Greenville, right? So these are hours away. And so sometimes, yeah, I had to send them that, you know, you have to leave straight from here, do not stop. You don't stop at go, you go, you know, you don't stop at home, you go straight to the burn center versus we're gonna treat you now, we're gonna give you some pain medication, we're gonna dress you, you're gonna show up at 8 o'clock the next morning at the burn center. Right, so there's a difference. But the biggest thing is, especially if you're not sending them right away, or even if you are, and you're actually bandaging them, try to get in between the fingers, okay? They will actually adhere to each other and be harder to treat. So you don't want to, you wanna make sure that you are putting gauze or something, a Telfa, something in between the fingers so that they don't stick to each other. If it's greater than 20% total body surface area, we're going to aggressively fluid resuscitate that patient. And most of the time, especially if it's greater than 20%, we're gonna most likely ambulance ride them to, or flight them to the nearest burn center. Alright, you have a 34-year-old female sustaining a thermal burn. While counseling the patient with the following features is best associated with a second-degree partial, or deep partial, sorry, I hate that, deep partial thickness burn. How are you gonna educate that patient who has a deep partial? What do you think? Who wants A? Who wants B? C? C? E? Yep, A is correct. Usually heal between 2 to 3 weeks. This class is 3 to 8.
Yeah, deep partial is 3 to 8.
Well, if they don't,
The upward superficial partial is 3 to 8.
fine. Thank you for, so superficial thickness, or a superficial partial is 2 to 3 weeks. Fine, thank you. Give me a little bit of break, today's my birthday. So show me a little grace today, okay, thank you. Alright, so phases of burn treatment, okay? This is just a really quick overview of the initial assessment triage, how we're gonna do fluid resuscitation, how we're gonna do the coverage, you know, in terms of creams and medications and whatnot, and then supportive versus critical care, and then rehab, right? Rehab is a very essential part of any burn treatment, and you know, in terms of like what happens, you know, within the first few hours, days, 2 weeks, to months, 2 years. Okay, so this is just a great overview. Again, you know how I love a good algorithm, so that is just a good overview. Okay, so in acute resuscitation, okay, so acute resuscitation. These are sometimes very, very hard to start kind of the initial thing. You still go through your X, A, B, C, D, E. You have to look for other injuries, but airway still has to be our number one. And especially for our massive TBSAs, and if you are anticipating, you know, if it's really more than 20%, we might prophylactically take their airway while their airway is still patent. Okay, we are gonna be giving these patients so much resuscitative fluid that we're anticipating them kind of swelling up to the Michelin Man, okay? That we are going to take their airway early. So this is one kind of disease process in which we're not waiting for them to decompensate. We are already preparing for them to decompensate, and we're gonna take their airway very quickly, okay? We want to cover the patient. So this is, if you guys have a burn rotation, I highly recommend you go. Be hydrated when you go, okay? Burn ICU rooms and the burn OR is routinely above 100 degrees, okay? Especially for our higher TBSAs because they cannot thermoregulate, okay? So we make their environment warm so that their body stays warm, okay? I have pictures of me completely soaked from head to toe when I was on my burn rotation. So like they lose their ability to thermoregulate, so their rooms are gonna be really, really warm. You will sweat. Okay, so just prepare for that and stay hydrated. Don't become a dehydrated casualty. We can use face blankets, but most of the time we're gonna use a warm room because a lot of times, you know, they're gonna be in wet dressings. So we're already making them cold because of their dressings, and then they're weeping fluid, right? As soon as we take that initial layer off, they're going to weep fluids. They're losing that skin's ability to maintain anything, okay? So awareness of increased fluid loss. Urine output is extremely important in this population, okay? If you're in a burn ICU, you have a Foley. Whether you can pee on your own or not, you have a Foley. Okay, we have to use your urine output as a guide for fluid resuscitation, especially after the first 8 hours. We can use other invasive devices to evaluate fluid status, ABGs, lactates. Slime gas catheters are more so a thing of the past. Now we're going to use the Vigileos and the flow catheters, okay, to really identify like what their status is. And occasionally, depending on if their belly is really, really burned, we can use the IVC, but most of the time their belly is burned and we're not gonna put, you know, unsterile gel onto a burn. So we're gonna stop there for just a second. We're gonna give you a 10-minute break, then we'll come back and finish up with complaints.
Is that the one where you saw the guy who does the dog?
Yeah.
She was willing to work with us. Like X-Men, some of the old X-Men came with stuff. Because she had Dark Phoenix used to be in that came out pretty recently. She's a villain in most of them. She's barely here. Part of the X-Men. You're gonna say 31?
All of mine started.
They start at 4? They start at 4. I measured from where the line starts. a bunch of it too.
It's not that many movies where he's in it. The Dark Phoenix takes over. And especially primary camera. He's in that. Most of the ones she's in,
You know what? Yes, they are. Yes, they are.
Even when he dropped calling my demise.
He's actually trying to keep the thoughts in.
Crazy how we talk, you just listen to the same song and always keep it like the amount of time. Yeah. One of the most realistic medical shows up. All the fucking it's love. Relationships.
That's gonna be my favorite part of phase 2.
It's a healthy.
I couldn't even go in there. What else got there? Syphilis? Did you watch Crazy Ex? Yeah, it was awful. Next time I was watching that, it was like, hold on, don't fucking come in here and think you're too cool for Grey's Anatomy or any like
Schedule.
Girl, like, do you watch Love Island? You don't watch
No.
Love is Blind?
Nope.
Grow up. Grow up. Toxic masculinity is what that is. Okay, so then do that. So you scroll on fucking Instagram Reels, and that's give what you want. Love is Blind. It is trash, but that's why we see your idea.
Yeah. Yeah. Do you have an average amount of killing stuff?
Alcohol? Nope. Never. Yeah, I've got 8 bottles of fucking my pod trailer will blow the fuck up if I take some higher.
People go.
Okay, cause I'm just saying, like, I gotta fill these blank spaces in my calendar.
That's a document.
It's like,
Yeah, I mean, like student education, they're like, hey, fill this paper. Are you still like, these two guys are
that's why I said.
Did you do a makeup check?
That was the issue that people left last interest.
Because you're killing me.
That's why. Yeah, I did.
Once we get out of here.
Right now, unless they change the name, so like times are good, things are not good. Yeah, exactly. She likes it. Yeah. Yeah, in the way that it might compromise really
All right. So, everybody back? Okay. So maybe I get into this. So like I was talking about, we use the urine output to really indicate like if they're resuscitated enough, and we'll go through some calculations in a minute to kind of, again, how are we going to influence the fluid resuscitation in order to get adequate urine output. Now, if we suspect that inhalation has occurred of superheated air or smoke or anything that could affect the ventilation, we need to get a carboxyhemoglobin level. Okay, this is normally ran with an ABG, so it's on the same kind of ISTAT cartridge, and so it'll indicate if there's carbon monoxide poisoning or carbon dioxide poisoning. So carboxyhemoglobin in anybody who has soot in their sputum and their nares, you look in the back of your throat and you see a lot of black. You want to get that, okay? Now the only other thing is if the patient is a heavy smoker, right? They're already breathing in that toxic air on a normal basis, so their carboxyhemoglobin is already going to be falsely elevated, because that's just their normal. Okay, so smoking cigarettes or cigars, cigarettes, whatever, will actually will have a false positive carboxyhemoglobin. Okay, so you just have to know if they smoke or not. All right. So when we're talking about burnt, right? Rapid loss of intravascular fluid and protein through the heat injured capillaries. So once your capillaries are injured, they're going to be, leaky. Okay, so you're gonna lose a lot of intravascular fluid. You're gonna lose a lot of protein, intravascular protein. Sorry. And the first is going to be like the greatest amount of loss is going to be within the first 6 to 8 hours. Okay. Normally we can have some capillary healing and returning towards our normal by 36 to 48 hours. You might have some, that transient increased vascular permeability, so that third spacing in the non-burnt, that's the Michelin man, right? We give them so much fluid, but the burnt tissues isn't just going to be the ones that are leaky. It's going to be everything. It's going to be kind of leaky. It's a systemic inflammatory response. So you have that shift of extracellular sodium and water into that intracellular space, so third facing. Okay. Can really drive some hyponatremic type events, as well as some other electrolyte abnormalities. And so if we can get the hemodynamic, if we can get some hemodynamic stability, then we can sometimes correct that third spacing, but especially in the first little bit until their capillaries kind of catch up, it's very, very, very hard. They're going to be at increased risk for developing that acute kidney injury from these high volume fluid shifts. Okay, so because of this inflammatory state, you're just going to have a lot of fluid shifts, and sometimes they're going to be on pressors. They may be on 4 pressors. They may be on everything underneath the sun to try to keep their blood pressure up. Okay, when we're talking about smoke inhalation, you have increased hemodynamic instability. We may have increased fluid requirements and increased mortality rates. Okay, so trying to catch those smoke inhalation patients before they decompensate is crucial. All right, so primary goal, foundation of resuscitation. Okay, we want to try to prevent burn shock. Okay, you have both a hypovolemic and a cellular shock. So you have decreased cardiac output, increased extracellular fluid, decreased plasma volume, and oliguria. So your kidneys are shutting down. You have not enough fluid in your plasma, but increased. So basically everything is going from intravascularly to extracellular, and decreased cardiac output because nothing is staying intravascular. Okay. So our goal is to restore and preserve the tissue perfusion and try to avoid ischemia and worsening that tissue injury. Okay, we want to try to keep the fluid intravascularly, which is super, super hard in these patients. With burn wound edema, okay, you have that significant transvascular fluid shifts, which then increase the total body permeability, okay, intravascular capillary permeability. So you're gonna have the decreased plasma volume, and like we just said, increase into extracellular fluid, the third spacing, and not enough intravascularly. Right. Let's see. So these are the people we want to give lactated drainers to. We want to try to have a bigger crystalloid that we can try to keep intravascularly within the first few. We don't want to necessarily give them normal saline. It's a kind of a, if we have to, we have to, but our initial fluid of choice is a lactated drainer for the isotonic components of it. Okay, so we want to try to provide enough fluid for organ perfusion, but hopefully try not to over volume them, so hypervolume. Okay, we want to try to prevent that, but give enough fluid to still perfuse our organs, which is a very tricky, very balanced resuscitation. Okay, so we have 2 formulas in which we use, for the most part, for how much fluid we need to give them. The first one is the Parkland formula. Okay, this is 4 milliliters times their total body surface area times their body weight in kilograms. Okay, pretty easy to remember calculation. We give whatever that is, that's half of that volume in the first 8 hours, and the remaining over the next 16 hours. Okay, we're targeting that urine output between 30 and 50 milliliters per hour, and then we're adjusting, okay, the urine output to at least 0.5 to 1 milliliter per kg per hour for an adult. Okay. If the urine output goes above that 1 ml per kg per hour, then we can decrease the IV fluids by 25%. So we can use that urine output to really indicate like how much do we need to increase the fluid, do we need to decrease that fluid per hour. Okay. So as an example, you have a 70 kilogram guy. He's got 40% total body surface area. So 4 times 40 times 70, that's 11,200. The half of that is 5.6. So you're giving 5.6 liters in the first 8 hours. Okay, so that's 700 milliliters an hour for the first 8 hours, and then the rest is over the next 16. But every hour, you're still trying to, you're getting that urine output. So even an hour or two, if that urine output is still less than 30, or like, let's say it's 15, we may increase to 800 milliliters an hour, depending on how their body is responding. Okay, if they're at like 70 milliliters an hour, we may decrease to like 600 and see how he does. So this is why they deserve to be in an ICU. They need every hour monitoring. Okay, so if we're in a massive resuscitation, they're going to an ICU. Now we have the other one called the rule of tens. This is sometimes depends on how your brain works. This is sometimes a little bit easier to remember. So you have 10 mils times your TBSA times your hour, okay? So you have 10, I hate this one, I don't like this one. But, so if you're between 40 kilograms and 80 kilograms, okay, this is your normal TBSA. So if you have, let's say you're a 90 kilogram guy, okay, your TBSA is 40%, your 40 times 10, that's 400, okay? But for every 10 kilogram over that 80, you have to add an additional 100 milliliters per hour. Okay, so say we have 90 kilograms, right? So 400, because he's 10 kilograms over that 80, we have to add another 100 milliliters per hour. So now he's at 500 kilograms, 500 milliliters per hour times 8 hours is now 4 liters. In that 8 hours. Okay? I don't like this one, but I still have to teach it to you. I like Parkland better. It's a little easier for me to do, but I think the ER sometimes will say that the rule of 10 is easier because it's only 10 times the TBSA, and then if you're over 80 kilograms, you add 100 for every 100 for every 10 that you are over 80. Okay? Your target urine output is the exact same. We're still going to increase or decrease depending on if you're between that 0.5 and 1. Okay, 0.5 to 1 milliliter per kg per hour is our goal. Okay, if you're over 1, we're going to decrease your fluid resuscitation. If you're less than 0.5, you're going to increase. Does that make sense? Okay, there are, like I said, examples on each of these slides, so you kind of have an idea of if you're, over 80, you have to add, so if say they're a 100 kilogram guy, you're gonna add 200 milliliters per hour above the 400 that his TBSA demands. Okay? If they're less than 40 kilograms, then you probably won't use this one. Okay? There is no decrease, you're not gonna decrease 100 if they're under 40. Okay, you're only gonna add if it's above 80. Okay. So, patient has suffered a 45% second-degree burn and is being resuscitated using the Parkland formula, which of the following is the best parameter to monitor adequacy of line resuscitation. Urine output, good. Okay. So wound care for the specific burns. Okay. Superficial burns, you're treating with lotions, ointments, mild pain medications. Nothing too crazy, right? You can use aloe. Aloe's great. You can use aloe with a little bit of lidocaine in it. You get that over the counter. Superficial partial burns, you're going to try to provide as clean an environment as possible to try to prevent infection. You do not require topical antibiotics. You can use an occlusive dressing to minimize exposure. You don't want to do that on the face. You're just going to leave that open with antibacterial ointment like bacitracin, ophthalmic bacitracin, okay, especially if it's around the eyes. If there's no infection, then the burn will heal spontaneously. Okay, you're just going to keep it clean and keep it moisturized. Basically it. Okay. For deep partial or full thickness, we need to prevent that invasive infections. These patients have opportunistic bugs. They will have the weirdest bug profile that you've ever seen. They have like fungal infections, Candida. They can have weird bugs that you've never seen or even heard of. So it really just depends, but we try to prevent infection. We want to remove that dead tissue as soon as possible, cover the skin with skin, or cover the wounds with skin or with a skin substitute as soon as possible. So excision and grafting, and we'll talk about that. And then them on the deep, partial and full thickness burns, okay? Because we want to prevent those invasive opportunistic infections. So when we're talking about topical antibiotic agents, these are purely superficial. The goal is to create just a moist environment, so you're not like putting gobs and gobs on there. Just a thin layer is fine. You want to, like we just talked about, try to protect against that microbial colonization. Systemic antibiotic prophylaxis pays like we do not put these people, even if they have severe full thickness burns, we're not automatically putting them on antibiotics. Okay, we're not going to prophylactically treat for an infection. Okay, so our most commonly used topical antibiotics is silver sulfasalazine. Okay, or silvadine is the more common name. Okay. It actually is soothing on application, okay, has like a cooling effect, protects against broad spectrum of microorganisms. Unfortunately though, it can create a transient leukopenia. So if you have a wide, surface area or a larger TBSA, we do have to, monitor the CDC and make sure that we're not causing a leukopenia. We have sulfamylon, okay, these are specifically for burns over cartilage, so ears, nose. It's a specific one that kind of prevents infection of the cartilage, okay? Can become painful though. It can kind of cause some stinging to it. It's not the most pleasant one, so if you don't need it, don't use it. Ophthalmic bacitracin for burn around the eyes, and then regular bacitracin for the rest of the face, if you need it. Okay. It's okay to put ophthalmic bacitracin over all of the face if you need to, but specifically around the eyes, regular bacitracin around the eyes is not good for the eyes. It can cause a lot of intraocular type of issues, so ophthalmic bacitracin to the face is just fine. Okay. All right. So debridement. So what do we have to do in order to remove the dead tissue? Right. Any loose skin and dirt should be debrided. Okay. When you're doing this, especially if it's a larger body surface area, we try to only uncover. We're trying to keep the rest of the body covered and warm. So we're going to really do like one area at a time. The only time that really doesn't, we don't follow that practice is when we're actually in the burn OR. They're intubated, they're sedated, their entire body is uncovered, okay? But it's over 100 degrees in that OR to keep them warm. We go as fast as humanly possible, and we normally have more than one surgeon in there and or more residents so that we can have one person on each extremity. Okay, we might have multiple people working in multiple areas to get it done as quickly as possible. But in terms of the clinic, if you have, arm and like maybe a leg, try to keep one area covered while you're doing the other area. Okay. You can do IV narcotics rather than IM. You want something that takes effect rather quickly. Make sure they have someone to drive them home if you're going to do this in the clinic. Okay. And then obviously update your tetanus on everybody who has a burn. Okay, that's the one prophylactic thing that we do. Everybody gets a tetanus shot, no matter, because it's an opportunistic thing. And so we want to prevent against tetanus. Okay, so you can kind of see here you have lots of loose skin. Okay, we're trying to actually remove anything that is loose and anything that is detached. Okay, you're not in the clinic, right? You are not excising anything that's still attached. Okay, you're only debriding the loose tissue. Okay? Anything that's still attached will either stay attached, or the next time you see them, it may have detached because it's kind of blossomed a little bit. So this is why close follow-up is extremely important. So first day, you can kind of see that first day, right? It's not as bad. Like even this area right here, okay, can everybody see this? This where I'm pointing? I'll point it on the other side if you can. But you can kind of see like right here, right? It's nice, it's normal skin color, but day 2 to 3, it's like gone. Okay, that's what I mean when it blossoms. It actually will look normal the first day, or maybe like look like a superficial. and then the next day, because, you know, everybody's cooked a steak in this room, right? We leave it, we cook it for, you know, so long, and then we leave it to rest because it's going to continue cooking. Same thing with tissue. Okay, it's going to continue cooking, unfortunately. So you have to kind of already anticipate that the burn might look worse if you're seeing it day 1 versus if they're coming to see you like day 3. It's probably already gotten to its max potential. So really close follow-up is really, really important. So on this side of the room, you can kind of see here, right? It's nice, healthy skin against the burn, and then here it's like already obliterated. That's day 3. So day 1 versus day 3, right? It's like it blossoms, right? You anticipate that it's going to get worse. All right, you have a 17-year-old female seen in emergency department with a 3rd-degree burn on her foot. That's a full thickness burn for all you normal people. Occurred 8 days ago. Now she has an S scar covering the wound. She's febrile. She has an elevated white count. And which of the following is the most appropriate next step in managing this patient? What do you guys think? Yeah, I did not do a great job of updating these questions. Yeah. So the answer is admit to burn unit for IV antibiotics, but I wouldn't say only because that SR needs to go. So sorry, I did do this late last time. But so we wouldn't necessarily do bedside debridement. We don't want to necessarily just start IV antibiotics, right? She's febrile. She has an elevated white count. It's on her foot. Okay. Even though it happened 8 days ago, now that she's got an eschar, she's got an infection underneath that eschar that eschar needs to come off. It needs to be debrided. She needs to have IV antibiotics in the burn unit. So yeah. I don't like any of these answers. Okay. But if you guys were to pick the most correct answer, it'd be E. Okay. She's gonna get admitted. She's gonna start out antibiotics, and then go from there. That's the next step, at least. Okay. I'm sorry. These questions are not great. For the last lecture, I did not do great. All right. Moving on. Maintenance of function. I'm hearing murmurs. Is everybody okay? Are you just, yeah. Remember, we're showing the grace today. Okay, so maintenance of function. We want to try to place clean dressings over top of burn area and change them every 24 to 48 hours. Most of the time it is every 24 hours. We have these silver impregnated dressings. These are great. And basically silver is an antimicrobial thing. It's a property, right? So the only bad thing about these dressings is we have to keep them wet. Okay? We can't allow these to get dry, so we really want them wet. So silver impregnated dressings, you have soap and water, we apply directly over burned area. We don't have to have any self-balancing, you don't have to do anything, we put these directly over burned areas. And so then we can, but we do have to rinse we have to take it off every day, but we also have to keep it wet. So throughout the day, if it starts to get dry in the unit, the nurses will actually put more saline on it to keep it wet, okay? Splinting the extremity in the position of function, not comfort, okay? We want to try to preserve function. So you'll see them in, hands spreaded or fingers spreaded type of splints, trying to keep the contracture at bay, okay? A lot of times the patients don't like it. It really depends on tolerance, but where it's not for comfort, it's for function. Okay. Excision and grafting. So when we need to actually excise the wound, okay, once we have that loss of hair follicle, we have that full thickness wound, you have no ability to epithelialize. Okay? Epithelial epithelial layer is already gone, it's already dead. So we need to get down to an area of active blood loss so that we can hopefully be able to get healing, or to the point where we can at least get a skin graft on. Okay. So like I said before, blood loss is substantial. We are basically cutting off the dead skin with these torture device looking things. They're called Wex. Okay, or a Watson knife or a Wex. Okay. These are, I had a burn surgeon hand it to me one, like my very first day in the OR, and he's like, yeah, just go do this leg. And I was like, sir, I have no idea what this is. So it is a tangential type of filleting. Okay, you're literally filleting the skin layer by layer off. Okay, to the point where then hopefully we get down to healthy bleeding so that we can then graft it. Okay, when we're talking about the 3 different types of graft, we have autograft, so that is from the person. Okay, we're taking the like a donor site, we're actually shaving off, doing a superficial or a deep partial, basically burn. Okay, but we're basically filleting that skin off so that we have that epithelialized layer that then we can put over that burn and hopefully heal. Okay, we'll go through that in a minute. If we use allograft, so it's from the same species, but maybe like cadaver skin. Okay, still has an epithelialized layer. I mean, it is used commonly, but it depends on how much they have. And then xenograft is actually a newer thing from other species. So you guys have probably heard in the news like the using of the tilapia skin. Okay, they sterilize tilapia skin and actually can use that as the xenograft, and actually they've had wide success. Like it actually works. So it really just depends on if the facility has that available to them. There's other species, but I think tilapia skin is the most common. If we can get them into the OR and do excision and skin grafting, it really improves survival. The earlier we can get in and take that dead skin off, the better they do. Okay, so when we're talking about grafting, there's 2 different real types. Okay, there's full thickness. So this is taking all the way down to dermis. Okay, full thickness of the dermis, and we do not perforate it or mesh it. Okay, so this is a full 1-to-1 graft. Okay, so we're taking it from the thigh, and we're basically then putting it on an area that we do not want to be contractured. Okay, so we want to do it for hands, joints, mainly the face. Okay, where we don't want, we want like superior cosmetic results and functional results. Okay, split thickness grafts is we can take that graft and then we throw it through another type of like torture almost device, right? But it's on the back table, and we take that graft and then it meshes it, so it makes tiny perforated holes all throughout it in a pattern. So think like a pie crust, right? Where instead of taking a full sheet of pie crust, covering the whole thing, versus you're making those surgical incisions along so you can spread it over a bigger surface. Okay, still has the epithelialized layer, and it'll heal from those layers, or from like the edges of each wound, of each hole in the meshed skin. Okay, versus then trying to heal from the wound edge out. Okay, does that make sense? Kind of. Okay, so each little hole will be where they close in, versus if there was no graft, it would have to heal from the actual burn edge in. Okay, so you're closing that area which the epithelialized layer has to actually close over. Okay, so we'll do split thickness or meshed graft over everywhere else. Okay, so if you see somebody who has this like almost grape-like appearance, they've most likely had a graft. Okay, so you'll see like the edges of the normal epidermis, and then you'll see actually where the epidermis kind of and the dermis closes in, but it doesn't rise normally to the like area where, or surface area where you actually see you know, just normal skin, you'll actually see the little perforations, but skin kind of dipped in. So you'll see it. I don't know if I have any pictures of that, but I can always find one. So when we're talking about complications of these, okay, the biggest ones that we have to deal with are circumferential burns, okay? Circumferential around the chest, belly, around any of the extremities, right? So if you have a full thickness burn, okay, you've lost the skin's ability to be elastic, okay? So now we've taken someone whose skin is no longer elastic, and we're giving a shit ton of fluid to them, right? Making them become a Michelin man. If their skin is not elastic to support that fluid influx, they're gonna cause a compartment syndrome in that extremity and or body area, okay? So what we do is called an aspirotomy, okay? Very similar to a fasciotomy, but we're not going all the way through the fascia. The fascia is not the problem, it's the dermis and the skin's inability to be elastic and flex with the fluid increase in their third space, okay? So it really impairs circulation, and so when you have those capillary leaks, it can actually cause that tourniquet type effect, where the skin cannot expand. Okay, you're gonna have pain out of proportion, similar to any compartment syndrome, and the treatment is aspirotomy. Okay, a lot of times, so the areas where on this little guy over here, where you see the darker black marks, are normally where we would make those incisions for aspirotomies. And you also have the dotted lines in which anywhere along those is where, you know, we would try to actually keep the black ones, and we would cut along the dotted lines. Okay, we're trying to preserve the tissue over a joint, just like we would with a fasciotomy, right? But we're cutting along those dotted lines to try to open up that area. So if you have a circumferential chest, right, your whole chest, okay, now you've lost the ability to expand every time you breathe. Now you add fluid to that, you even have more of an inability to breathe and ventilate. So we'll actually do an H-type incision. Okay, we'll cut on either side of the chest, basically kind of like here, and then across where the diaphragm or the rib cage would be. Okay, so that actually allows for the belly and the chest to expand to allow for ventilation. Okay, the skin is insensate. It's a full thickness burn. Okay, so we do not sedate, we do not use lidocaine or anything like that, they're not going to feel it. Okay, so we don't have to, they're going to be sedated anyway, because if they're this bad, they're going to be intubated and sedated, but we don't necessarily have to do like a local anesthetic in the skin because it's not going to hurt. Okay, we're cutting through dead skin. And if this ends up being something where you're doing this in a local ER and you don't have a burn center in that hospital, you're life flighting them to a burn center. Okay. All right. Hypermetabolism. So when we have a profound burn, okay, our body is thrown into that inflammatory state, and our body's metabolism goes through the roof, okay? Really, it's going to be activated by the pro-inflammatory cytokines and oxidants, okay? You have profound hypermetabolism and metabolism in a post-burn period, and so these people need extra nourishment, okay? They need extra protein, extra food, if we can get it in there, because they are going to go through all of their energy stores very, very quickly. Okay, pain, cooling, sepsis syndromes increase. Okay, their hypermetabolism. Okay, so they're going to be in pain, most likely. They're gonna cool, be hypothermic because they've lost their ability to thermoregulate. And if they become septic, okay, their body is just not gonna be able to handle it. So, we need aggressive nutritional support, okay? As soon as we can close those wounds with those grafts, they're gonna be better. If we can help control the pain, deal with sepsis and hopefully prevent sepsis, we can really help control this state. But this is also part of the neurostorming process a little bit. And so for both neurostorming as well as this metabolic state, we can give a beta blocker. So we give propranolol to a lot of these patients to try to decrease their heart rate. They're still going to be tachycardic, but we can hopefully help decrease that metabolism and hopefully kind of get them into a normal metabolism state. But really, so and we'll talk about this, any burn center, especially in their ICUs, will have a dedicated nutritionalist or a dietitian who's basically, their whole job is to make sure that the nutritional support of these patients are met. Okay, because their metabolic demand is going to be exponentially higher than their normal state. Okay. All right. So rehabilitation of the burn patient, wound contractures is our next biggest thing that we have to deal with after their initial resuscitation. So now they're not really acute. They're now healed, and so now we're trying to get them back to a functioning state. Okay. Just like I said, in terms of their burn, right? Their burn edges, even if we do graft them, most of the time they still will contract ever so slightly. But if we don't graft them, they're going to contract. And so what we can do, if they are in a weird area of contracture, we can do this Z-type scar, and then hopefully help elongate that area, okay? This is really gonna be from a reconstruction, like a plastics team. A general surgeon and a burn surgeon isn't gonna be doing this, okay? You will have specific plastic surgeons who just specialize in burn reconstruction, okay? So these are very, very, very specialized plastic surgeons who do this. So it's called a Z-plasty. Okay. All right, electrical injuries. So when we have electrical injuries, we can have the electrical, as like the actual current injury. We can have the electrical thermal burns, and then flame burns from those electrical, from the electrical burn. Okay. When we are dealing with electrical burns, the outward appearance is probably going to be a lot less. It's really the internal path of that electrical current is what we need to worry about. Okay. Because electricity will traverse bone, muscle, nerves. So you'll see this is a really bad hand burn. Okay. But between this, what we call entrance and exit wound, right? Between the one hand, all of the internal structures to the other hand is a potential for injury. Okay, so it's not just the surface, it's everything that connects where that electrical current entered the body and where it exited. Okay, so you will have an entry and exit wounds, but just like with GSWs, we try not to say well, this is an entrance, this is an exit. This is just these are where the current entered the body and potentially exited. Okay. Often we'll need fasciotomies, okay, from the internal structure damage and edema. When we're talking about, the types of voltages, residential, you'll have more of a low voltage. If it's industrial or lightning, you'll have more of a higher, greater than 150 volt voltage injury, okay? And especially with the industrial and lightning injuries, you're going to have extensive underlying damage. Okay, you may only have one little tiny area of burn that you see outwardly on the skin, but the internal damage is extreme. Okay. These are most oftenly admitted to the burn unit. They will have continuous cardiac monitoring, most likely or from the cellular damage, leaking of potassium. Okay, hyper-K is super, super common with these guys. Their kidneys are going to be hurt because of the severe myoglobinemia. So the breakdown of muscle, the death of that muscle is going to kind of almost like a rhabdo picture. Okay. Even have that same urine output of 0.5 to 1, but we're also gonna do CK checks and CMP checks every 4 to 6 hours on these guys, okay? And then, serial, evaluation of those extremities, especially the long bones, making sure and kind of evaluating for compartment syndrome, making sure you don't need to do that fasciotomy and doing it early so you don't miss it. Alright, for, kiddos who, who potentially had or bit a cord and had an electrical burn from that, normally we don't need to debride anything, normally there's no surgery initially. We'll splint it, to help prevent a contracture and then reconstruction of the mouth after it's healed. Chemical burns, remember acids will do coagulation necrosis, alkalines will have liquefaction necrosis, okay? You're removing all the clothing, if there's a dry powder, you try to brush it off as much as possible. And then for all the other ones, you're doing copious amounts of water. If you don't know, call your burn center or your poison control to figure out whether it's going to react with water or not. Okay. You want to split in the position of function, elevate and dress, and send to a burn unit. Okay, so burn center considerations when to transfer in or have the patient evaluated with by burn center. So if you have a partial thickness greater than 10% of your TBSA, you have any third degree burns, electrical burns, including lightning. The fact that the ABA says that, explicitly said lightning, I'm not sure why, but if you have someone who's struck by lightning, send them to a burn center, right? Any chemical burns, inhalation injury, burn injury in patients with pre-existing medical disorders that can complicate management, prolong recovery, or increase mortality. So your complicated diabetics who have already a poor healing history, your immunocompromised patients, you want to send those to a burn center, and then any burns that have combined trauma. So like they were burned and they were burned from an explosion, right? So they had blast injury, they were potentially they had other trauma other than just the burn. They should be seen at the burn center. Okay. Okay, we already talked about all that. All right. So which of the following patients with burns is most likely to be managed without a burn center admission? Who wants A? B? C? D? E? So everybody agrees with A? Okay. Little 3%. Partial thickness, total body surface area is called on the back. Yep, they don't need to be seen by a burn center. Alright, those are something you guys can take care of. If it gets worse, obviously send them. If you don't like it, send it, but realistically 3% is pretty small. Okay. Alright, admission orders, nothing really new for any other burn or any other admission. It's just adding that CK and the carboxyhemoglobin if it was positive, the lactate to trend those. Everything else is pretty the same. Like there isn't really much different in terms of admission orders for a burn patient. Okay. Now other burn center burn unit considerations, they also take our ECMO patients most of the time, our TENS patients, and our SGSs. Okay, so anything that has significant dermal or epidermal injury, okay, you have somebody who has, large amounts of road rash, okay, that are deep road rashes, that's still a epidermal and dermal injury. They could theoretically be put into a burn unit if their, TBSA, their actual abrasion is significant, okay? Team approach, we have a dedicated staff, so the attending surgeons, intensivists, PAs, whatever, one-to-one nursing, right? They have a one-to-one nurse. They do not have a 1-to-2 nurse. It's very, very rare to have 1-to-2 nursing because that nurse is round the clock. Like they have a computer in their little vestibule inside of their room. so they can actually visually see the patient at all times, okay? We have a respiratory therapist, PTOT dietitian, behavioral health team, social workers, district planners. They are isolated private ICU rooms, okay? They are, isolated from other patients because their opportunistic bugs are super, important to try to limit, okay? 3 hours, not too bad. Okay. Any questions?